The available data show us that we have essentially highly effective options across hormone and non-hormone therapies. For most people, hormone therapies should be first line. They're safe, effective, and usually cost effective as well. But we also have we haven't had head-to-head trials, but the non-hormone, particularly the neurokinin antagonists, seem to have really high efficacy on par with some of the hormonal options. And the way that I think about it is really thinking who is a good candidate or not for estrogen. If they're a good candidate, then I'll typically start with hormone options. And if they're not, or they prefer not to use hormones, I'll use the non-hormone. I think every clinician needs to be taking a good history and finding out about patients' personal risk factors. And most people will be candidates for estrogen, but there are some really important contraindications, and it's important that we know those. But some ones that I think really we've fallen into a trap of finding too many contraindications, some of which don't actually exist. So some that might confuse people are the history of migraines with aura is actually not a contraindication to hormone therapy. Also, a family history of breast cancer is not a contraindication. So really getting familiar with what those things are: active liver disease, undiagnosed bleeding, stroke, MI, all of those things would be contraindications. But then there may also be intermediate risk patients. We also, I've been doing some work with a group of awesome menopause docs where we're creating medical eligibility criteria grid for hormone and non-hormone use. And I'm really hoping that that will help clinicians triage. So there's more nuanced treatment decisions. Real world effectiveness, they all, in my opinion, are fairly comparable. And I really guide my decision based on potentially other secondary symptoms. So, for example, if somebody's hot flashing and not sleeping, gabapentin may be a great option. And because it will help with their sleep, it's pretty effective with vasomotor symptoms. All of them, the estimates are pretty wide, but have an average reduction of severity and frequency of about 60%. If somebody is having mood disturbance as well as hot flashes, I might go with an NRI or SSRI. That being said, just to note, the doses are different for vasomotor symptoms. Those doses tend to be much lower than the treatment doses for depression and anxiety. So you need to be mindful of those nuances. The neurokinin therapies are so exciting because we finally have an FDA approved non-hormone option that's really efficacious, something that I can say, it's like estrogen and then everything else. We finally really have something that can hold a candle to estrogen therapy for vasomotor symptoms, and that's awesome. Um, I think it fits in for patients who prefer not to use them, who maybe are older and not good candidates for hormone therapy, and certainly for oncology patients where hormone therapy is not advised, and those people tend to have really severe vasomotor symptoms. Those are great candidates for using those therapies, and I think um, Elinzanetant fits in right with fezolinetant. I think one of the biggest constraints is that there's too much to talk about in a short amount of time. This is really probably a two-visit topic, one of a really good history, one of counseling and treatment decisions. So I think it takes time, and finding that is hard. I also think it takes really listening to patients, understanding what they've tried, what their goals of care are. And really the good news is that really this is an individualized shared decision making conversation, and it's really important to take the time to do this well.